Hi, I'm Steve Russell, and I want to thank ARVO for allowing me to present this work on behalf of my co-authors through this video forum on the results of a phase 1b2 open-label dose escalation study to evaluate the safety and effects of a novel antisense oligonucleotide, sepofarsen, otherwise known as QR110, for Leber's congenital amaurosis type 10 due to P-cis998X mutations in the CEP290 gene. My disclosures include that my institution received grant funding from ProQR Therapeutics, which was the study sponsor. All other author disclosures are listed here or can be found at the arvo.org site. This trial was a 3-site study conducted at the University of Ghent and Hospital, at Shea Eye Institute, University of Pennsylvania, and Wills Eye Hospital, and the University of Iowa. Leber's congenital amaurosis, or LCA, is a group of largely recessively inherited retinal diseases that affect photoreceptor cells from birth. LCA10 is among the most severe forms of LCA, leading to early blindness and often to light perception or no light perception by early adulthood. It is caused by biallelic mutations in the CEP290 gene, which leads to disruption of photoreceptor cilia function and photoreceptor degeneration. Despite poor visual function, these subjects often have an island of poorly functioning photoreceptors, but structurally intact outer nuclear layer, as illustrated in the middle right panel. LCA10 accounts for 20 to 40% of LCA, and one particular mutation, P-cis998X, may account for more than half of these. This mutation accounts for up to 21% of all LCA, making it a particularly desirable treatment target. The P-cis998X mutation introduces a new cryptic splice donor site deep within the intron 26 of the CEP290 gene that results in alternate splicing of the pre-mRNA and premature termination. The resulting shortened mRNA leads to nonsense-mediated decay, or a non-functional CEP290 protein. Sepofarsen, or QR110, is an endonuclease-resistant antisense short RNA oligonucleotide that blocks the cryptic splice site, resulting in normalization of CEP290 mRNA splicing and production of full or near full-length CEP290 protein. In this study, inclusion criteria were subjects with LCA10, ages 6 years or older, although the youngest recruited patient was 8 years old. The first cohort enrolled were 3 adults treated with vitreous injection of a loading dose of 160 micrograms in the worst eye, followed by maintenance dosing of 80 micrograms every 3 months. After safety assessment, 3 pediatric patients were enrolled at that dose. And in parallel with the first cohort, a group of 3 adults was enrolled at the higher dose of 320 micrograms, followed by 160 micrograms at 3-month intervals. After DSMC review, 2 additional pediatric patients were enrolled at the 320/160 microgram dose. Subjects were seen at least every month for 12 months, and the primary outcome was safety and tolerability. Secondary outcomes were the effect of sepofarsen on potential registration endpoints, including best corrected visual acuity, full field light sensitivity testing, or FST, and mobility. At baseline, 5 subjects ages 15 through 41 had a visual acuity of light perception in both eyes. The best baseline visual acuity measured was 0.63 logmar, or about 20/80 Snellen equivalent, in a 14-year-old who was homozygous for P-cis998X. Overall, the 160/80 microgram cohort started with a better visual average logmar acuity. In the 320/160 cohort, there were more light perception patients. All subjects completed the full 12-month study, and after a 320/160 microgram dose subject developed a cataract and the DSMC review was performed near the midpoint of the study, the dosing interval was extended from every 3 months to every 6 months. The most common adverse event was the development of worsening of cataract, or development of cataract, in 3 of 6 subjects in the 160/80 microgram cohort and 5 of 5 in the 320/160 microgram cohort. In 6 cases, the cataracts progressed, interfered with visual acuity or assessments, and were treated with cataract extraction and intraocular lens placement. In all 6 cases, visual acuity returned to pre-cataract treatment responsive levels. 2 cases of cystoid macular edema and 2 of retinal thinning not associated with anterior or posterior inflammation were noted in the 320/160 microgram cohort in 3 individuals. None of these findings was associated with a reduction in visual acuity. For the 2 cases of cystoid macular edema, topical steroids stabilized or ameliorated the adverse event. For the 2 cases of OCT detected retinal thinning, both stabilized in 1 to 3 months. We have continued to monitor all subjects for at least 12 months, and no additional or ongoing cases of CME or retinal thinning have been detected. The mean change in best corrected visual acuity, full field light sensitivity, and mobility improved compared to the better seeing contralateral eye. The graph on your left is visual acuity with the treated eyes shown in green and the uninjected in yellow. The middle graph shows FST for red and blue light, with treated eyes shown in more intense hues and uninjected controls in lighter hues. For both of these graphs, downward represents improvement. For change in mobility shown on right, green represents treated eyes and yellow the uninjected eyes, and upward represents improvement. The mean visual acuity in treated eyes improved by 0.55 logmar, or between 5 and 6 lines of improvement in treated eyes versus 0.12 logmar in untreated eyes. The mean difference was statistically significant, and the magnitude was greater than 0.3 logmar, or a 3-line improvement, which is accepted as clinically meaningful. Red and blue FST demonstrated improvement in light detection of almost 1 log unit, or nearly 10-fold increase in sensitivity. For both stimuli, the difference between the treated and untreated eyes was statistically significant. And finally, we tested a mobility course tailored for the low level of visual acuity typical of LCA10, and the difference between treated and untreated eyes did not reach statistically important significance in this small study. Shown here is a waterfall plot of the 160/80 microgram cohort on the left and the 320/160 cohort on the right, ranked in order of the greatest visual acuity improvement. The starting visual acuity in logmar is shown at the top of each subject's column, and the final acuity is shown at the bottom. These results suggest that the 320/160 dose does not result in better visual outcomes. Also, 2 subjects had outstanding improvements in acuity, but this plot shows that 1 LP patient and all non-light perception patients contributed to the mean improvement. 67% of subjects had a responder rate of 0.3 logmar, and 83% had a 0.2 logmar improvement. And note the asterisk represents the 14-year-old homozygous subject for the P-CIS998 mutation. In summary, this study demonstrated that the primary adverse event associated with sepofarsen is the development of cataract, which responded to conventional cataract management. Except in the youngest pediatric patients, younger than those eligible for this study, the trade-off of cataract to stabilization or improvement of LCA10 is manageable and provides potential positive benefit to risk ratio. Cystoid macular edema unassociated with inflammation and retinal thinning were seen in 2 eyes each in the 320/160 cohort and appeared stabilized or improved at study conclusion. Perhaps more important, no systemic adverse events or serious adverse events were encountered, and the AEs related to the injection procedure were mild and self-limited. The most encouraging aspect of this trial was the surprising finding of mean improvements in visual acuity and FST, and in some instances, unexpectedly outsized improvements, even in a subject with baseline light perception vision. Before this trial, stabilization of vision was the expected outcome, but these clinical data demonstrate the potential for rapid and meaningful improvements of vision for subjects with LCA10. Subjects continue to be followed in the extension trial, from which we may learn additional safety or contralateral eye response information. Based upon this data, recruitment has begun for a phase 2/3 multiple dose, double masked, randomized, sham-controlled trial of sepofarsen for LCA10. Thanks for your attention.
Thank you, Dr. Russell, for that nice review of the phase 1/2 trial for sepofarsen. My name is Ben Shaberman. I'm Senior Director of Scientific Outreach and Community Engagement at the Foundation Fighting Blindness. And I have a few questions. First off, Dr. Russell, can you describe the differences between RNA therapy and gene therapy, or gene augmentation therapy as we sometimes refer to it?
Sure, although there is some blurring between the two. I guess the easiest way to understand the difference is that gene therapy involves placing augmentation of genes or adding new genes to a cell, or removing the function of a gene, as opposed to RNA therapy, in which one is trying to manipulate or change the way the RNA reads out the genetic information.
Are there certain types of mutations or genes for which RNA might be a better option than gene augmentation therapy?
So gene augmentation is particularly advantageous when one has a recessive disease and one needs to simply replace a non-functional copy or place a functional copy in the cell. We are still struggling with methods for using gene therapy in situations where we have dominant disease or gain of function disease. And in those cases, we need to be able to neutralize a gene. And RNA can in many cases, provide a mechanism for being able to inactivate a gene. Or in the case of CEP290, in this case, to modify the way in which the gene information is being transmitted to the cytoplasm through the mRNA, and can essentially correct one of the copies of the mRNA. So in situations where, especially in these diseases that have induced or mutations that cause splice donor sites, RNA is a super approach that uses a small molecule rather than a complicated compound drug approach that requires a vector, because you don't need a vector for this. This is injected straight into the vitreous. It's a much lower risk procedure. And so, yes, there are certain kinds of mutations in which the RNA approach makes much more sense than a gene therapy type approach.
And my question was also targeted toward the size of the gene. Can you talk about whether RNA might be a better option for a certain size of gene?
Sure. So currently, the only approved vector for the eye is the AAV2 virion or capsid. And so that has a limiting size that one can put within that vector. And so for larger genes, and CEP290 certainly is one of those, as is the Stargardt gene and some other very common ones, we don't have the cargo capacity to be able to transfect those genes into cells. So we just don't have a vector currently. A number have been tested, lentiviruses and a number of others, but so far we're left with essentially treating only small genes with gene therapy.
Do you feel that intravitreal injections have been both safe and they're feasible to get the treatment to where it needs to be?
Yeah, for this particular drug, and for probably most RNA constructs, intravitreal injection would appear to be a reasonable approach to administration, and has a much lower risk profile than subretinal injection, as you can probably imagine. Also, most treaters or most ophthalmologists have experience with intravitreal injections. Very few of them come out of any training at all without having done them. And so it's a more universally available skill.
My next question is about identifying the appropriate patients for these trials. how are you finding people with the specific mutation in the CEP290 gene?
So I'm depending on my colleagues heavily who have followed many of these patients for years and have identified them genetically. And I would encourage anyone who sees patients of this type that if you do not have the interest, skill, or willingness to evaluate them, that one should consider referring them to an inherited retinal disease specialist so that they can be evaluated, or a pediatric ophthalmologist that has an interest in inherited retinal diseases.
And as a follow-up question, I just wanted to confirm something that you said in your presentation that I think is really remarkable, and I want to make sure I understand. But did you say that 21% of all LCA patients have this one specific mutation in CEP290?
That's right. So there have been a number of estimates as to the frequency of the various LCA subtypes. But LCA 10, which is the CEP290 mutations, are clearly the largest group of LCA. And in at least one study, the rate of this particular mutation occurred in 51% of the patients. So it appears that this may be the most common mutation that causes LCA.
And the results for mobility, visual acuity, and FST were all relatively impressive. Did you get some nice anecdotes from patients after they received treatments about how their activities of daily living may have changed?
Yes. So that's kind of one of the great ironies of science, right? You present all the data and everybody, sort of scratches their chin and is concerned about the statistical significance. And one or two anecdotes seems to break right through, and people seem to understand how impressive some of these visual acuity improvements are. We had one patient who improved so much that he was able to go back to being a carpenter. Measure twice, cut once. And actually, he got what would you say, enthusiastic that he was helping a friend of his re-roof his house and fell and hurt himself, resulting in an SAE that was unrelated, obviously, to the treatment itself. But he ended up getting hospitalized for a broken bone because he got so his visual acuity improved so much that he started doing things that he probably should not have done.
Thanks. That's an interesting observation. And I have a two-part question. If somebody has an inherited retinal disease and they're interested in a clinical trial, what steps should they take to learn about clinical trials and get connected? And then part two of that question, especially if somebody thinks they have CEP290 or may have symptoms that indicate they may have that form of LCA, what should they do to get on the radar screen of people like yourself?
Sure. So obviously the best place to start is with your local inherited retinal disease specialist if you have one. If you don't have one, then I would encourage you to talk to your medical provider or your retina specialist, pediatric ophthalmologist, or general ophthalmologist, or other who is advising you or you trust. The other thing is that there are a number of websites that are helpful. There's I think it's myretina.com. I think it's a FFB site, as a matter of fact, that has current information on open enrollment of studies. One can also go to clinical trials, which is the FDA registration site can be a little difficult to navigate. So it may be better to go through your local provider or through the FFB website, or contact one of the people that are known IRD specialists that are involved in the area.
Yes, and given I'm with the Foundation Fighting Blindness, I can say that website is myretinatracker.org.org. And as a follow-up to this question, how important is genetic testing for most patients and families?
So 5 years ago, I would have said not important. But in 2020, the answer is it's crucial, because you don't know what's available unless you've been tested. And thank you for correcting me on that website.
You're welcome. It's part of my
your job.
But do you feel as though sepofarsen is impacting people with both early stage disease and later stage disease?
I think one of the big takeaways from the data is that it appeared that every patient who had visual acuity better than light perception improved, but even one of the patients with light perception improved dramatically. So the problem is, in advance, you don't know based on visual acuity whether somebody is going to respond or not, at least in this small cohort. And again, we're talking about a really small group of people here. We're not going to know a significant amount until we're done with the phase 3 trial. There aren't a lot of things that you can measure, by the way, especially in a pediatric patient population with visual function this low. And the problem with CEP290 is these patients can become light perception at a relatively young age, even into single-digit ages. So this is, whether they have an central island of photoreceptors that are potentially rehabilitatable remains the question, I think. There probably will be some structural limitations in who's eligible.
And do you have a sense for whether it's rescuing rods and or cones?
Well, the only evidence that I can think of in which that bears on this is the difference in the FST. Typically, full field light sensitivity tests are done with either a red, a white, or a blue light. Red is particularly good for responsiveness of the long wavelength cones, or cones in general, because it stimulates red and green cones, and most cones are either red or green. And blue would stimulate either blue cones or rods. But obviously, there are typically more rods than there are blue cones, except perhaps in a disease like this where we're so physically restricted to the fovea. So, but the only evidence, I guess, in terms of how rods are responding or may respond would have to do with the fact that the blue FST also showed an improvement. And so some subset of that response may be rods. It may be cones, blue cones, or short wavelength cones, but it may also be rods. We don't have any visual field evidence of improvement. Frankly, most of these patients have such a constricted visual field that we were not able to obtain meaningful data.
If I interpreted your slides correctly, it appeared that the lower dose of the two doses worked as well as the higher dose. And my question is, do you think, or as you move forward in the clinical trial, are you still going to evaluate different doses?
So that would be up to the sponsor to make that decision. But I think what we have discovered from this study is that the more concerning adverse events, which are cystoid macular edema and retinal thinning, only occurred at the 320, 160 dosing. So, and they did start, that cohort did start out with a slightly worse baseline vision, so I can't say for sure that they wouldn't have done as well as the 160/80 group. But clearly the 160/80 group did perform better, and perhaps that was a baseline shift. But certainly that demonstrates that that is an effective dose, or appears to be an effective dose in this small cohort. So I don't think there's any. We've essentially established the maximum dose that may be used in the phase 3, but I do think that there may be some reasonable reasons to look at lower doses.
Dr. Russell, thank you for that insightful presentation on an encouraging emerging therapy. And thank you for answering all the questions that I asked. And we appreciate your time and your work to get this therapy out to the people who need it.
Well, thank you. And I'm sure that all of us appreciate the work that FFB has been doing over the years and continues to do. And thanks for all the work that you're contributing now. Stay safe.
You too. Thank you.